Hi everyone, this is Tim, your Block 3 lecture instructor, and today's voiceover PowerPoint is going to be on diabetic ketoacidosis, also known as DKA. It's also going to be on hyperosmolar hyperglycemic state, which is also known as HHS. This is not the most exciting PowerPoint. There's not a lot of pictures, and I do some reading because I found information to be a little bit more comprehensible on these two subjects. I'm trying to make this as simple and as easy as possible for you guys to understand, and so try to bear with me as I go through this. Let me know if you have any questions. So, what is DKA? When your cells don't get the glucose they need for energy, your body begins to burn fat for energy, which produces ketones. Ketones are the chemicals that the body creates when it breaks down fat to use for energy. So, essentially, what's happening is that your diabetic patient, because DKA happens to diabetics, your diabetic patient is not consuming enough food or not consuming any food at all. For whatever reason, whether them having a cold or flu, whether they're having some GI problems, or maybe just lack of being able to eat anything. Because of that, they need energy, and what their body will do is actually break down fat to get that energy, and that byproduct of breaking down the fat is what they call ketones. If there's enough ketones, then it's going to make their blood very acidic. So in a nutshell, patients who are diabetic will need some sort of energy, breaks down fat, and because of that, their ketone level will go higher, and that's DKA. So what causes this? There's actually several reasons why this can happen. Maybe the patient is not taking enough insulin. Maybe the patient did not inject insulin and they need more insulin than usual because of illness. So patients, especially diabetic patients, we already know that illness, stress, inflammation, medications. There are several reasons why a diabetic patient will have high blood sugars. And if they're not consuming enough, again, their body's going to break down the fat in order to get the energy, and because of that, the ketones will rise. So if they aren't consuming enough and balancing that with the amount of insulin they're getting, then they're going to get DKA. Maybe they didn't actually consume enough food. Again, if they're sick and they're not consuming enough food, their body will actually break down the fat and cause the ketone level to rise. Maybe your patient's actually having an insulin reaction. You've learned in block 2 something called the dawn phenomenon. It's when a patient that's diabetic takes their insulin before they go to bed, and halfway through the night or around 3 or 4 in the morning, their blood sugars actually drop to about the 30s and 40s. Because of that, in order for them to survive, their body will actually break down the fat in order to get the energy to get their blood sugar levels to increase to a somewhat normal level. And because of that, their ketone levels will increase. So there's a couple of reasons why your patient's blood sugars will rise and the DKA or the ketones will actually start to rise too. All right, so symptoms. Your patients who have DKA are going to have thirst or very dry mouth. They're also going to have frequent urination. I want you to remember that any orifice of your body that expels fluid, it's because it's trying to maintain homeostasis and trying to get rid of whatever is ailing it. So for DKA, your body is trying to get rid of the ketones by actually urinating them out. It's not a great plan and it doesn't actually work, but the body's trying to do what it possibly can. And so the frequent urination is to try to get rid of the ketones. The patient who has DKA is also going to be constantly tired. They're also going to have dry or flushed skin. They're also going to have nausea and vomiting and abdominal pain. So again, their body is trying to maintain homeostasis by trying to get rid of the ketones and to try to lower the blood sugar. It may do this by actually causing nausea and vomiting. They're also going to have difficulty breathing. That difficulty breathing is going to smell very fruity, and it's because of the fact that ketoacidosis, one of the symptoms of that is low serum bicarbonate, low pH, low PCO2, and your body, again, is trying to compensate and maintain homeostasis. So your patient is going to try to breathe all the acidosis off. Again, it doesn't actually work, but it tries what it can. Those respirations are actually called Kussmaul respirations. So again, it's trying to blow it off. Another symptom is going to be the fact that they're having a hard time paying attention and might have some sort of confusion. For diagnostics, your patient is going to do two things. One, they're going to check their blood sugars as often as they possibly can to make sure that their blood sugars stay within some sort of normal range. And they're also going to test their urine for ketones. They're going to test those, I think, according to this, it's me every 4 to 6 hours. And that's to make sure that the ketones don't rise too high and also to maintain a proper blood sugar level. If not, again, it's going to get out of control to the point where they have to actually come to the hospital and get interventions. I threw in this slide here for sick day rules. I know that you guys have learned it before, but I want you to kind of stick with it. For patients who are diabetic, who are not feeling well and consuming enough food, they are to actually check their blood sugars every 2 to 3 hours to make sure that their blood sugars stay within some sort of normal range. They're to continue taking their insulin even when they are sick because they want to keep them, around that 100 to 200 mark. Make sure that the patient actually eats enough carbs and drinks enough fluids. It's hard to, for them to do this because they're not feeling well and they're not able to either consume stuff and keep it in them, or food just doesn't look good at all. But they should try something, whether it be crackers or toast. You can do the brat diet. I mean, get something in them in order for them to be able to keep their blood sugar lower and for their body to stop breaking down the fat that it needs for the energy. I know that energy drinks aren't the greatest, but I know they're full of sugar, but in the same sense too, they're also full of sodium and potassium, and they also will keep your patient as hydrated as they possibly can. They're going to check the blood and urine for ketones every 4 hours. They're going to take their fast-acting insulin in order to keep their blood sugars at some sort of normal level. So for an assessment, once your patient gets admitted and they're actually put on the med-surg floor, there are several things that you're going to do. You're going to check EKG for dysrhythmias. You're going to check their labs for potassium and sodium level, because with all that urination and possibly with all that emesis, they're going to lose potassium and sodium. You're going to check vital signs. You're going to make sure that their blood pressure isn't too low and that their heart rate is too high, because that's a sign of severe dehydration. You're going to check for ABGs based on that respiratory acidosis. You're also going to check breath sounds and make sure that they're not either not breathing well enough, or because you're checking for those small respirations. You're also going to check for a Neuro Check, especially with the mental status and cerebral edema. You're also going to check their blood glucose. You're probably either going to check it every hour, or you might actually check it more often than AC and HS. And you're also going to check for eyes and nose. You want to make sure that whatever is going in is what's coming out, or vice versa, because either one, what's going in is not coming out, which means that they're getting fluid volume overload, or what you're putting in is actually coming out more, which means that they're actually more dehydrated, or the interventions you're doing are not working. And those interventions are going to be this, and this is actually very important. This is something that we do on every DKA patient and every diabetic with blood sugars that are extremely high. So because of their dehydration, because of the fact that their body was constantly urinating and trying to flush out those ketones, their blood pressure and their heart rate blood pressure is going to be low, heart rate is going to be really high. But again, you're going to be severely dehydrated. So you're going to maintain their fluid. The first thing you're going to do is give them normal saline, 0.9%. It's going to be 1 liter over 1 to 2 hours. Again, this is to actually go back into the vascular system and to actually hydrate them, bring their blood pressure back up to a normal level and their heart rate down so it doesn't have to compensate. After that 1 to 2 hours, you're then going to switch them over to 0.45 or half normal saline with 20 of K. This is two things. One is to help keep them still hydrated. It's also now trying to hydrate their cells. The 20 of K, or the potassium, is to help replenish the potassium they actually lost because of all the insulin they were giving themselves, or because of all the dehydration they were having, which was depleting their potassium levels. So this is to help replenish that. You're going to do this until the blood glucose is below 250. Once they get to about 250, you're going to switch them from half normal saline with 20 of K to D5 half normal saline. Now, it seems kind of odd that you'd actually go from normal saline to something with dextrose in it. But the reason why is because you want to hydrate them first, hydrate them in their cells second, and then you actually want to continue hydrating them in their cells, but you don't want to keep dropping their blood sugar from, let's say, 800 down to 100. Their body can't react to that very quickly, so you just want to drop their blood sugar slowly but surely, and allow enough time for their body to react to that. Electrolyte imbalances. So the more insulin a diabetic person takes, the more it pushes the potassium back into the cell and out of the bloodstream. So that's why the half normal saline with 20 K is also used. It's to not only replace their potassium that they've lost based on the fact that they're dehydrated and urinating it all out, but you're also replacing the potassium back into the bloodstream that was actually essentially pushed into their cell because of insulin. So, you want to make sure that their insulin is, or their potassium is within a certain limit. So, after you've done these things, you're then going to start them an IV insulin. It's going to be regular. This is going to be after you give them 1 liter of normal saline for hydration. You also want to make sure the potassium level is 3.3 or above. And the reason why is because once you start them an IV insulin, it's going to continue pushing the potassium back into the cell, which means they're going to lose more and more potassium. So if it's 3.3 or higher, then you can start them in the IV insulin, and then what you're going to continue doing is actually give them potassium in other routes. If they're able to tolerate orals and keep them down, then give them potassium pills. If they're not, then you can actually continuously give them IV potassium in order to get their potassium back up. You're also going to check their blood sugar every hour and their potassium levels every 6, because you can't just give potassium and hope that it works. You actually give it, and you're checking every 6 hours to make sure that what you have done is actually working. You're checking the blood sugars every hour because 2 things. One, you want to make sure that the IV insulin that you're giving them is not too much and driving them from 250 down to nothing. Or you want to make sure that what you are giving them is actually working, and that you don't find out, several hours later that you've given them half a bag of insulin and you're finding out that it didn't do anything. So, so these labs are really just to kind of, you've done an intervention. Let's, prove that what you've done actually works. Now, as far as acidosis management, this actually will resolve itself. Once you hydrate your patient and hydrate them vascularly and also interstitially, the acidosis will start to actually resolve itself, because now not only is the ketones starting to be less because of the insulin you're giving, but you've also went from a very concentrated blood supply or circulation to very hydrated blood supply, and this actually kind of thins everything out. And your labs actually should go back to normal, because remember, when they're concentrated, everything is high. That doesn't mean that they're high because there's too much of it. It's really just because there's not much floating around there and stuff. So the more hydration you give them, the more it starts to thin it out and actually starts to correct those labs. Now, I threw this in here. I know this is what was like 2 slides ago, but I hope this makes more sense. So you're still doing an EKG because of the fact that you're really affecting them with the insulin IV that you're giving them. It's making their potassium lower. You're also hydrating them, which also kind of thins it out a little bit, which could potentially make their potassium lower. The EKG is to make sure that that you're not affecting the heart in some way. Again, you're going back to the labs. You're making sure the potassium and the sodium levels are within some sort of normal limit. Vital signs should go back to being normal. So blood pressure should be 120/80. Heart rate should be roughly in the 80s. Each one of them is not trying to compensate for anything anymore. ABGs should go back to normal because of the fact that you hydrated them. Breath sound should go back to normal. You're still going to do neuro checks to make sure that whatever hydration you gave them is not fluid volume overload, because with all that sodium, it's actually going to cause some cerebral edema. Blood glucose, again, you've actually checked every hour. You're making sure the insulin isn't either too much or not enough. And again, you're going to do isonos. You're making sure that if you are giving these several liters of fluid, that they are getting it, you've hydrated them, but once the input and output start to equal each other, then you've truly maintained hydration. So as far as evaluation, once the patient's blood glucose is below 250, potassium is within some sort of normal limit, and they can actually tolerate a diet. Their diabetes is controlled with sub-Q insulin instead of IV insulin, and education is complete, they get to go home. Now, the reason why I say education is complete is because of several reasons. One, either they're a compliant diabetic and they were trying to do what they could at home and they just got too much and they couldn't. And it's not their fault. I mean, it's not like they're not doing anything. They were trying to keep themselves in the hospital. They were trying to do all the right things. They were trying to fix their blood sugars. They were trying to, get healthy again and get over what was causing them to be ill. It's just too much and they couldn't. Remind them of the sick days. Remind them of eating the crackers and the toast and trying to consume something in order to keep them from breaking down the fat. Making sure they're checking their blood sugars, making sure they're actually taking their insulin, making sure they're doing all the right things. And again, you're not really necessarily blaming them. You're just trying to remind them. You also have the ones that are non-diabetic or non-compliant diabetics. Those are the ones who probably got sick, caused their blood sugars to go up, but they really weren't doing much in the first place to correct anything. So now you have to start over, and you have to go back to reminding them what they need to do, which is checking their blood sugars, consuming enough good nutritious food, or at least trying to consume something while they're sick. They're a little bit harder because the fact that, when patients are sick, they just don't really want to be taught. And if they're not really listening to anything prior to this, then they're definitely not going to listen to you again. So the education is very important, because if you're not going to fix it, or if they're not going to help them fix it, then they're just going to be back in the hospital again. All right, so next up is hyperosmolar hyperglycemic state, or something known as HHS. So I already read this paragraph and it makes absolutely no sense to me at all. But I also don't want to really record this. So anyways, what HH truly is, it's hyperglycemia without ketosis or acidosis. So it's just like the DKA, but it only happens to type 2 diabetics. And because type 2 diabetics do have some sort of insulin production, and don't necessarily need the actual fat breakdown, the ketoacidosis is not present. That's essentially what this really means. HHS is most commonly occurring in patients with type 2 diabetes who have some sort of illness that leads to reduced fluid intake. So this is also another paragraph that probably makes no sense, but I will point out several things. One, it does happen to type 2 diabetics, and it also usually affects more elderly and chronically ill patients who are more bedbound or do not have the means to be able to consume enough fluids to keep themselves hydrated. The reason why I say this is because as much as we believe that patients come to the hospital, especially the ones that are bedbound, that we feed them 3 meals a day and we put them on fluids and keep them hydrated. We think that we actually do a great job on giving them, water to drink and food to eat and stuff, but we really don't. The reason why I say this is because of the fact that I have patients that I try to take really good care of, and I try to feed them the 3 meals, but you're trying to get grandma to drink something and she just doesn't want it, and you can't really force it. You can put them on fluids, and for hydration and stuff, and yeah, they're getting the hydration, but it may not necessarily be enough. Or one other thing that this actually paragraph says too, which is very important, is that a lot of the infections that are causing this HHS are usually pneumonia or urinary tract infections. Those two disease processes are prevalent more in elderly adults than any other population. So, patients who have COPD or have CHF, if they're not consuming enough fluids orally, yes, you can give them maintenance fluids, but then you can't give them too much, because then you're actually causing fluid volume overload, or you're causing more stress in the heart, or you're causing them not to be able to breathe as well because of the COPD. So there's a fine balance, but then something's got to lose. And I think for the most part, this HHS is usually because, again, this is for the type 2 diabetic, the ones that are severely or chronically ill, that can't either consume enough oral fluids or can't tolerate the maintenance fluids at a high dose to keep them truly hydrated. Let's see here. So again, I mentioned the elderly, the chronically ill. Let's see here. Another thing too is that one thing I didn't mention is, patients who are demented. Those are the ones who are fighting you every day on eating and drinking and stuff. I had a patient this last weekend that had brain abscesses, and she was pleasantly confused. And I did actually help her eat her meals, but she wasn't always drinking as much as I was trying to get her to drink. And I couldn't put her on fluids because of the fact that she did have COPD and congestive heart failure. So again, there's trying to be a fine balance, and she wasn't having HHS, but the whole point is that her even being pleasantly confused didn't make it any easier for me to actually feed her and try to give her enough hydration to keep her hydrated. All right, so patients with underlying renal dysfunctions, congestive heart failure, or both are at increased risk for HHS. Other things that can also increase the HHS is drugs that raise serum glucose levels, inhibit insulin, or cause dehydration. Alcohol and cocaine could also cause the dehydration and the HHS. Anesthesia, antiarrhythmics, antidiuretic medications such as see here, probably Lasix, Aldactone, things like that, anti-epileptics, antihypertensives, antipsychotics, beta blockers, corticosteroids. We talked about the diuretics, histamines, and also statins. This is a lot of medications that are pretty common for everybody to take. So, don't be surprised that, again, I think the book even says this is very rare in people, but when it happens, it really truly does happen pretty hard. So. Symptoms are going to be increased thirst or urination at the beginning of the syndrome. Your patient is going to feel weak. They're going to be nauseous. They're going to have weight loss because of all the urination. They're going to have dry mouth and dry tongue. Again, they're dehydrated. They're going to have the fever because of the dehydration. The seizures probably because of the lack of sodium. The confusion, same thing, coma. Symptoms may get worse over days or weeks. This is not something that happens overnight. Other symptoms that may occur with the disease such as the CHF, the COPD, the pneumonia, the UTIs, things like that. Loss of feeling or function in the muscles because of the potassium levels, problems with movement, and speech impairment. So for assessment and diagnostics, your patient is going to have extreme dehydration. They're going to have fevers higher than 100.4 degrees, increased heart rate because of the fact that they're dehydrated. Their blood pressure should also be low, and the heart is trying to compensate. You're also going to check for eyes and nose. Diagnostics are going to be blood osmolarity, blood and creatinine levels to make sure the kidneys are actually functioning correctly. You're also going to do a blood sodium level, ketone test, blood glucose, evaluation for possible causes that maybe include blood cultures. Maybe there's another form of infection. Do a chest x-ray to rule out the pneumonia. You're also going to do an EKG because of the potassium levels and a urinalysis to find out if there's possible UTI. So with all that said, I had to throw hypoglycemia in there. So it's basically your blood sugars that are less than 50 or 60. This could be due to the fact that you took too much insulin and didn't eat enough, or you've actually had some excessive exercise, or you didn't consume enough food after you took your insulin. Symptoms are going to be sweating, tremors, tachycardia, palpitations, nervousness, and hunger. For the central nervous system, it's the inability to concentrate. You have a headache, you have slurred speech and drowsiness, and you also can have severe hypoglycemia, which is disorientation, seizures, loss of consciousness, and death. The way you fix that is going to be fluids. It's going to improve their blood pressure, urine output, and their blood sugar, and you're also going to check their potassium and sodium levels to make sure that they're within normal limits. The insulin, you want to make sure that you didn't give them too much, or make sure that they didn't give themselves too much and possibly didn't eat enough. And the management of it is going to be give them 15 grams of fast-acting or concentrated carbohydrates, 3 or 4 glucose tabs. You can also give them 4 to 6 ounces of juice or regular soda, not diet soda because that doesn't help them at all. retest the blood sugar glucose in 15 minutes. You're going to retreat it if it's actually not hitting the 70s. I would rather you continuously try to fix it and then go from 30 or 40 or 50 up to like 150, 200, 300. I would rather that happen as opposed to you slowly, surely going up slower and slower and slower. Because we can always fix, hyperglycemia. You're in the process of fixing hypo, but if it's taking too long, you're not really doing much. Provide a snack with protein and carbohydrates unless the patient plans to eat a meal within 30 to 60 minutes. So at the hospital, we check the blood sugar before meals and before they go to bed. We will give them insulin based on what their blood sugar is and what they're also going to consume as far as a meal. Sometimes they don't eat all that you thought they would have, but you'll recheck it to make sure that they're not too low. And again, you're really looking at signs and symptoms to make sure that it isn't. And if it is, then again, we're going to have to try to correct that. For emergency measures that the patient cannot swallow or is unconscious, you're going to give subcutaneous or intramuscular glucagon, which is 1 milligram, or you can also do 25 mLs to 50 mLs of 50% dextrose IV solution. Again, sugar water, so you're trying to bring their blood sugar back up. I've also mentioned before that we can always do, take the sugar packets. You could put sugar in the under the tongue or within their gum line. You can also do jelly, icing, things that is very high in sugar. You can put them in their mouth, not necessarily for them to swallow because they're not conscious, but if you can put it someplace to where it's very vascular and it can start absorbing it, it will actually help with that too. I threw this in here because I actually found this, which I thought was a little bit interesting and may help you understand the difference between DKA and HHS. You don't have to necessarily memorize it, but it's just like, it's a matter of what the differences between the two are. So with DKA, it's more of the ketones, and it's because of the fat breakdown and the byproduct of that, whereas HHS is because they're type 2 diabetics, but it's some sort of other illness that's causing the problem, and because of the dehydration, because of the excess fluid loss. So let me know if you have any questions, and we'll go from there.